Good morning, everyone. My presentation is our experience with a single-piece sutureless scleral fixation hydrophilic foldable IOL. So no financial disclosure, no conflict of interest. It often feels like a ultimate goal in cataract surgery is implanting an intraocular lens. However, as soon as the posterior capsule or the capsular circle is compromised, the uncompromised outcome of this simple yet skill-demanding surgery comes crashing down. Some patients come to us pre-existing condition that cannot accommodate with a routine PCR, like dislocated IOLs, dislocated nucleus, PCR. So and what option do we have? Either we can go for ACL or iris claw lens, anterior, posterior, or we can go for a SFIOL. But we have done this option. We have tried the CMT Flex IOL. The specifications are, it's a hydrophilic 26% with an optic size of 6 mm. Overall size is 13.75 mm with a dioptric range is minus 15 diopter to 55 diopter. And it's a 10-degree angulation that this is helpful to us because it's not going to rub on the surface of the iris. My study was on 10 patients. It's a prospective study and we have done around 10 cases. So we have calculated the IOL power with the Barrett Universal 2 and kept same as PCIOL power. So this is one of my case. I'm showing you the video. All the steps I'm showing to you. So as you can see, this is very important. You have to make a tunnel on both the sides with parallel to each other. I generally prefer 3 and 9 o'clock positions. This is because the tunnel is very important because below that the T which will come out from the tunnel will going to rest over it and going to protect it, and the T haptics will not going to fall. So this is another important step, that is with the MEHERDA will make a sclerotomy in both the sides from where the IOL will come out. So this is the T part and this is the optic part. The T is a very important part. So we should be ready with our forceps which we have designed, and we are injecting the lens in a foldable way and we are just holding the T part of it, it is coming out, and then the other side is coming out. So you can see the T part, you have to check everything after that. You have to hydro it properly and you don't have to suture it because there's no leakage. So you have to cover the flap and no need for sutures. So this is another way we can go by injecting through a tunnel. So you can see we have zoomed it with a microscope you can see clearly how the T pops out. This is the T part pops out and another T can be delivered either directly or through the holding through the optic haptic junction, then putting the forceps from this side and bringing the other haptic from the sclerotomy. This is called the handshake technique, in which what we have to do is we have to hold the optic haptic junction with the help of a dialer or with the help of a forceps, and with the help of another forceps which we have designed, we have to bring it out, and this you can see the another side the T is popping out. So this is the handshake technique to deliver the other part of the T. So this was another case of mine with PCR and there was a iridodialysis. So we thought of putting the CMT IOL through the tunnel. So you can see we are putting the IOL and we're ready with our forceps and bringing it out from one side. So here the T pops out, but what happens is we saw the other T got stuck in the mouth of the sclerotomy. We just saw it and we bring it out. So now the surgery is completed, almost the lens is centered. So these are the forceps which we have designed. They are completely different. Their dimensions, their measurements are completely different from the other SFIOL forceps because they are going to hold it properly. So we have increased the length as well as we broadened the tooth. So that it grabs this T part of it very good, and this is the curved forceps which we have made so that we can manipulate easily to hold the T part of the CMT Flex IOL when it goes above the iris. So these 3 forceps which we have designed and we are going to patent it also. So these are the cases which we have done. And the results which we have found out that 4 patients mild corneal edema, 1 patient with high microcystic edema, and 1 patient was having low intraocular pressure. So maximum vision which we have got was around 6.9 and also 1 patient got 6.6. So these are some of the pics which I am showing to you within a week and within 3 weeks. Almost the cornea was clear and the lens is centered. So discussion, it is easy to use, very well centered. T-haptics are self-retaining, good for the cornea, can be done using a tunnel or by injecting, non-irritating for the patient. So I just convey it's a safe and easy to learn. Thank you. Some references and thank you.
Okay, ma'am. Have you ever noticed any sagging? Like, do you take white to white in this of patients?
No, we don't take white because there's a standard dimension 13.75 and they don't.
But all eyes are not same, na? So, have you ever like?
No, we have not taken.
And have you ever noticed the T getting broken because of the stretch?
In one case, the T was broken. I have observed that. Then we have changed it. Just in one case. Then we thought we don't have to pull it. We just have to drag it slowly and slowly.
So that was not mentioned in this, na?
It was just one case.
Okay.